Chapter 19, Nursing Care During Obstetric Procedures. An amniotomy is the artificial rupture of membranes. It's done typically to help labor progress. There are a few risks that can occur with this procedure. The first is a prolapsed cord. This happens when the water is broken before the baby is well engaged into the birth canal. Instead, the baby is higher in the uterus. Many times, they do not like to perform the amniotomy until the fetus is at least at the -2 station, but many prefer -1 station. If the amniotomy occurs when the fetus is still high, there's a chance the umbilical cord will come down with the gush of fluid and get compressed between the fetal presentation and the woman's pelvis. That compression will decrease the oxygen that gets to the fetus. You will see a decrease in the fetal heart rate, which can then cause fetal hypoxia or acidosis of the fetus. Another risk for the amniotomy includes infection, as now there is an open passageway to the uterus that can cause infection to mom or to the fetus. There's also a risk for abruptio placentae, which is when the placenta prematurely breaks away from the uterus. The technique is that the provider will use an amnio hook, which is pictured in your book, and while doing a vaginal check, will use that amnio hook to put a small tear in the membranes and the amniotic fluid will come out. Nursing considerations include obtaining a baseline fetal heart rate prior to the procedure. You assist with the procedure by putting extra blue chucks on the bed to help absorb the fluid and obtaining the amnio hook for the provider. After the procedure, you're going to monitor that fetal heart rate, listen and look at the monitor, change the pads under the patient frequently for comfort, and it would decrease the risk of infection as well. Document the color, amount, consistency of fluid. Once the water is broke, it is standard of care to monitor the temp every 2 hours to monitor for signs of infection. Augmentation of labor is considered to be helping a woman's labor progress, where an induction is more initiating labor. If a woman is dilated to 3, have regular contractions, then performing an amniotomy is an augmentation because it's helping that labor process. Induction is typically when the woman isn't in labor, but they give medication to artificially start the labor process. Indications for either of these need to include 39 weeks gestation, unless medically indicated to do sooner than 39 weeks. They can induce for postdates, which is after 40 weeks gestation. They can induce for infection to mom or fetus, hypertension of mom, or other medical condition that puts mom or infant at risk. Determining if an induction should be done uses the Bishop scoring system. The chart they use to determine is Table 19.1. The likelihood of a vaginal birth is if the Bishop score is above 8. They're looking at dilatation, effacement, fetal station, cervical consistency, and cervical position. A few contraindications include placenta previa, which is when the placenta is covering all or part of the cervix instead of being implanted high in the uterus, if the baby is not in the cephalic position, if mom has had more than one low transverse abdominal incision from previous C-section, and maternal heart disease are just a few examples. One way they can induce labor is by cervical ripening. This means they are using an agent to make the cervix more favorable for a vaginal delivery. Medication methods include by using prostaglandins to ripen the cervix. This is typically done with a vaginal insert that is placed intravaginally or intracervical. Examples of meds are on Table 19.2. The medications Prepidil or Servidil are placed while on the OB unit and where they can be monitored on the EFM. Many times they are given at nighttime so the woman can still get some sleep. They can stay in place for up to 12 hours and then removed. Sometimes another dose needs to be placed, or other times they will move on to oxytocin after that. A pill Cytotec can be inserted vaginally. This can be redosed every 3 to 6 hours. Mechanical methods is where they use a transcervical catheter. This is like a Foley cath that has one or two larger balloons, and they will inflate once it's placed in the cervix. The balloons will put pressure on the cervix and causes it to dilate. Typically, the catheter will fall out when she's dilated to 4 centimeters. Oxytocin is a medication used to induce labor. Oxytocin is needed to initiate contractions. A woman's body will typically release oxytocin to start the labor process, but for some women, they need the medication form for this process. It is a powerful medication, and careful monitoring of fetal well-being and contractions needs to be done throughout the labor process. This medication is diluted in isotonic fluid and administered via IV pump. It is piggybacked into a main line of non-medicated fluid. The nurse will titrate the dose according to policy. It is typically increased 1 to 2 milliunits every 30 to 60 minutes. The woman must have continuous EFM when the medication is in place. The nurse must have good assessment skills and monitor frequently for fetal compromise or uterine tachysystole. Remember, that's more than 5 contractions in 10 minutes. Fluid retention can lead to water intoxication, so good I&O monitoring is needed. The medication is typically increased until she is in a good contraction pattern. This is generally contracting every 2 to 3 minutes and making cervical changes. If mom or baby is not tolerating, then the Pitocin does need to be decreased or shut off. Internal version. A version is when the fetus is not in the head down position and the provider tries to get the fetus to turn into head down position. This can be done as an internal version or an external version. An internal version is where the provider reaches into the uterine cavity with one hand while the other hand is on the maternal abdomen and tries to get baby to turn into the cephalic position. This can be done with a single birth or twins. It is not uncommon in twins for the second infant born to have turned after the birth of the first one and not be in the cephalic position. Contraindications include uterine malformation, suspecting a large baby, and oligohydramnios are a few reasons they should not be done. Helping reduce the anxiety in mom at this point will be crucial. External version can be used in a near-term pregnancy to get the fetus to the head-down position. A non-stress test is done prior to the procedure to ensure there's no fetal compromise. The woman will come to the unit, non-stress test is done, and if it's reactive, they can begin the process. Vitals will be obtained and her prenatal record is reviewed. A saline lock should be placed, and many times a tocolytic drug, which is a drug used to relax the uterus, is given prior to the version. Ultrasound is used to help guide the fetus to the correct position. If the version is successful, they may induce labor right away so the fetus doesn't change positions again, or they will monitor for at least 1 hour and then send her home and wait for her to go into labor. Once again, reducing her anxiety by providing emotional support and keep her informed is necessary. An operative vaginal birth is one in which the provider needs to use a traction device to assist with the delivery. The two methods that can be used is a vacuum delivery or a forceps delivery. Indications for either of these types include when that second stage of labor needs to be shortened. This can be due to fetal compromise, medically necessary for maternal reasons, or due to maternal fatigue and unable to successfully push out the fetus. It is preferred to do a cesarean birth if feasible instead of the operative vaginal birth, but sometimes the fetus needs to be born now, so the cesarean birth is contraindicated. Risks include maternal laceration, hematoma of the vagina, perineum, or periurethral area. A large episiotomy may be needed as well. The fetal risks include ecchymosis, facial and scalp lacerations, cephalohematoma are a few. There are pictures of the forceps and vacuum in your book. The forceps resemble salad tongs, and they're placed on the side of the fetus as mom is pushing. The provider gently pulls the forceps to help guide the fetal head for delivery. For the vacuum, the cup is placed on the fetal head, and while mom is pushing, the provider pumps up the vacuum causing a vacuum seal and helps guide the fetal head out as well. Nursing considerations prior to either of these is to assist with emptying the maternal bladder to make more room for the fetus, to make the descent for delivery. Fetal heart rate is assessed during both procedures, and after delivery, both mom and infant are assessed for any injuries that could have occurred during the delivery. Episiotomy is an incision to the perineum made by the provider right before birth. The provider will numb the area with a local anesthetic if an epidural is not in place. An incision is made to make more room for the infant. The incision is typically a midline cut towards the rectum. Nursing considerations included during the procedure to assist the provider as needed. Monitor fetal heart rate until birth. After the procedure, monitor mom for excessive bleeding, any swelling or bruising at the site, and for any signs of a hematoma.